Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theaters with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
A very warm welcome to all who have tuned in on a Sunday morning for this webinar on psoriasis and psoriatic arthritis, an overview presented by the Naruvi Hospital's Vellore in collaboration with the Hindu under its wellness series. Psoriasis is a strange ailment which is perhaps neither a norm nor an exception. Yet it is known to be a common chronic skin disease that causes rash with itchy skin and scaly patches in different parts of the body. Our three panelists today, all of them from the Naruvi Hospital's Vellore, will take us through this disease called psoriasis, thought to be a problem of the autoimmune system. To understand what is psoriasis and what causes it, I would like to invite first Dr. Monica Jain, who will speak on the clinical features of the disease. Dr. Monica is a dermatologist. She did her MBBS from Government Medical College, Kakinada, and her master's from Kasturi Medical College, Guntur in Andhra Pradesh. She has 3 years of work experience in Vadodara, Gujarat, and is currently working at Naruvi, Vellore. So it's over to you, Dr. Monica, for your talk on clinical features of psoriasis.
Yeah, sure. I hope my screen is visible.
Yes.
Yeah. Thank you for the warm introduction, Ms. Soma. A very good morning to one and all attending today's session. I feel honored and privileged to be invited as a speaker and to be sharing a platform with such eminent speakers today. So today I'll be discussing about the clinical features of psoriasis. So defining psoriasis, it is a systemic, not a skin-limited condition. So it is a systemic condition, and basically it is an immune-mediated disease that is most often characterized by. So how does it look like? So it is characterized by well-demarcated. You can see clearly demarcated erythematous, red-colored or skin-colored plaques. That is, plaques is nothing but elevated skin lesions, which are adherent with micaceous scaling. So you see silvery white scaling over it. And the prevalence of the condition is about 0.44 to 2.8%. So coming to how does it look like? So the most common type of psoriasis, it can present in various morphologies. So we'll discuss about the most common type, that is a plaque type of psoriasis, that occurs in about 80 to 90% of the cases, where you can see red scaly plaques, like you can see here, the red scaly plaques, which are elevated lesions. In Indian skin, they may not be as red as this. You can see either skin colored lesions or they can be hyperpigmented. But they are remarkably well demarcated from the surrounding normal skin, that is unaffected skin. And they're surmounted, these plaques, these elevated lesions, they're surmounted by silvery white scales. So you have white scaling over the plaques. So this is a morphology, how it presents. So how many lesions will I have? So you can have as little as a single lesion. You may have 3 to 4, 10, or you may have multiple lesions. So you may have multiple lesions all throughout the body. But when multiple, they are usually monomorphic, that they look similar and they're distributed symmetrically. So what sites on my body will be affected? When you think of what sites, we discuss the most common sites involved. That is the scalp, the extensors. So usually the extensors, the elbows, the knees, the extensor aspect of the legs, as you can see in the images, these are usually involved. And when involving the scalp, the most common question that comes up to the mind is, do you have hair loss when you have scalp psoriasis? So scalp psoriasis per se is usually not related to hair loss. So that is less likely. So as we have told, it usually involves the scalp and the extensors. Sometimes you may have lesions over the flexors when we call it as flexural psoriasis. So apart from all these variants, the common sites, sometimes your scalp, extensors, none of them are affected. You have lesions only on the palms and the soles of your feet when we call it as palmoplantar psoriasis. Also, the nails may be affected. Nail may be the sole thing affected, or it is usually affected when you have more extensive psoriasis, and nail involvement is usually related with your psoriatic arthritis, where you have joint pains associated with the condition. So what nail involvement do you see? So you can see nail pitting as shown in the image, or you can have ridging and grooving. But salmon patch is a condition, the oil drop sign which you see in this image, that is the most specific sign of psoriasis, but that is less likely to occur. Not very rare, but yes, less likely than the other variants. So as we have discussed the most common type of psoriasis, let's discuss the other variants of psoriasis, like the guttate psoriasis. So in guttate psoriasis, what happens is you have tiny, guttate is nothing but raindrop sized lesions. So the size of a raindrop, you have lesions spread all over your trunk usually. And the next variant is erythrodermic psoriasis, where you can see more than 90% of your body surface is involved, which is a rare condition, and but it is a life-threatening condition. And you have also obesity-associated psoriasis. Obesity in being itself an inflammatory condition, so the pro-inflammatory pathways, it predisposes to the development of psoriasis. And the other variant is the active or unstable type of psoriasis. So the next question would be, if I have 4 to 5 lesions, will my lesions increase? Will it stay the same or will it decrease? What happens? So one of the features which indicates the activity of the disease is the unstable or the active form of psoriasis. Sorry. So when along the lines of scratching or along the lines of trauma, you have lesions, that is called as active form of psoriasis. And the last entity discussing the pustular psoriasis. So other than the common skin colored elevated solid lesions, sometimes you can have a sheet of erythema or annular patch of erythema with some amount of scaling, and where you have pustules at the border of the lesions. That is called as pustular psoriasis. So when can I have this condition? At what age will I get it? So there's no age, like you can say, okay, if it is 40, I will not be getting it at any age further. So you can get this condition at any age, but usually more commonly seen in the third to fourth decade of your life. But yes, there is also congenital psoriasis, which is very rare. But yes, it can occur in children also. And those with an earlier onset of the disease, when you get it in childhood, usually there's a family history, like some of your parents might be suffering, grandparents might be suffering from it. One condition which we need to keep in mind is a napkin area of psoriasis, like diaper dermatitis in infants, which, if it is resistant to treatment, we need to rule out psoriasis in such conditions. And guttate psoriasis is a condition which usually occurs in less than 14 years of age, usually, like not per se, we can't tell so, but usually occurs in childhood after a streptococcal infection. So people have a sore throat. After about 2 to 3 weeks, the psoriatic lesions start on the body. So, okay, I have these lesions. So, what's the problem I'll be facing? Will I have pain? Will I have itching? So, what will happen to me? So, what happens with those lesions? So, yes, the most common, sometimes it may be asymptomatic also, but the most common symptom is pruritus. That is, you have severe itching over the lesions. And as we have discussed, the palmoplantar, like on the palms and soles, when you have lesions, sometimes there'll be tiny fissures, small cuts in the lesions, fissures that causes pain. So, in that case, you'll have pain. And in case of scalp psoriasis, more than itching, you're more suffering with you have shedding of skin from the scalp. So that is more of a problem. And not to be ignored, the feeling of embarrassment which people face due to the stigma. And the other systemic involvement, the joint pains or the articular symptoms, which Dr. Raja sir will be discussing in detail. And also sometimes the mucosal and the ocular involvement will be there in cases of extensive psoriasis. So before ending my session, I would like to discuss a few myths associated with psoriasis. Firstly, that psoriasis is contagious. No, it isn't contagious, because how do we know it is not contagious? When we know how it is occurring, then we know it is not contagious. So each of your skin cell keeps shedding, which is usually not visible in normal people, which is known as a skin cell turnover time. Each cell generates and then it falls off. It dies and then it falls off, which is not visible in normal people. But in cases of psoriasis, the skin cell, it usually takes a month for this entire cell to form and then shed off. But in people with psoriasis, the skin cell turnover time has come down to about a week. That is because of the immune and the genetic factors. So it can't be transferred to others even if they touch it. So feel free to hug, snuggle, or kiss your loved ones. And the next myth associated with this is that psoriasis is just a skin condition, so there's nothing to worry about. No, it is not just a skin condition. There is a high chance of the other systemic involvement. So in 20 to 30% of cases, you have psoriatic arthritis, and you're at higher risk of developing heart diseases, diabetes, and vision problems. So in any skin condition, mental health is never to be forgotten. So it is associated with the mental and emotional cost. And given the stigma associated with psoriasis, the sufferers are at higher risk for depression and suicide. The next myth is that psoriasis isn't curable, so there's no hope. So is this myth true? Yes, although it's true that there's no cure for psoriasis, it doesn't mean it isn't treatable. So we can treat it in such a way where we can live life more comfortably and freely. Yes, there will be a certain amount of redness or hyperpigmentation, like black spots, might stay behind, but your quality of life will improve greatly once you take treatment. So, ending my session with a small, tiny message that psoriasis isn't contagious, but awareness is. Now, right now, after the talk, as all of us are aware that psoriasis isn't contagious, I would like to pass that message on. I would like you people to pass a message to others. And thanking you. Thank you, the Hindu and Naruvi Hospital, for this opportunity. Yeah.
Thank you. Thank you, Dr. Monica, for that very detailed explainer on psoriasis.
Thank you,
So
ma'am.
once psoriasis is diagnosed, next, of course, comes the management of the disease. And we have our next speaker, Dr. Renu George, to speak on the subject. Dr. Renu is Senior Consultant Dermatologist. She has earlier worked in Christian Medical College, Vellore, as Professor and Head of Department of Dermatology, Venereology, and Leprosy. Dr. Renu has had also worked stints abroad in Adelaide, South Australia from 1993 to 1996 and in Brunei from 2005 to 2007. Dr. Renu is known for establishing the Pediatric Dermatology Service at CMC Vellore. She has been a member of the Indian Association of Dermatology, Venereology and Leprosy Academy and a member of the Standard Treatment Workflow for Dermatology with the Indian Council of Medical Research under the Health Ministry. With 98 publications to her credit, Dr. Renu's special interest is in pediatric dermatology, autoimmune connective tissue diseases, and cutaneous lymphomas. So over to you, Dr. Renu, for your presentation on management of psoriasis.
Thank you for your kind introduction. Let me just go to my slides. Okay. My slides visible?
Yes, ma'am.
Okay. Thank you for that kind introduction. And thank you, Monica, for the excellent talk. Good morning to you all. So what I'm going to talk to you about is the treatment of psoriasis in adults. Now, the road that I show there is a reflection of the treatment of psoriasis. It's a long and meandering one, and your physician is going to hold your hand through the various bends and bumps. So when you first go to a dermatologist, what is it that they're looking for? They diagnose your condition, and that's done essentially based on clinical features. They assess severity, and then they tailor the treatment, choosing medicine, taking into account the risk-benefit ratio and the cost of treatment. They also screen you for the comorbidities that Dr. Monica just alluded to, and they give you and if they give you a long list of investigations, believe me, they're trying to help you. And then, of course, we identify the risk factors for psoriatic arthritis, which is the most common comorbidity. Now, this slide is not to frighten you, but to tell you what has happened to psoriasis through the centuries. So in the 1800s and right up to 1995 or so, we largely believed that psoriasis is a skin disease. But with the turn of this century came an explosion of data which actually showed that psoriasis was linked with almost every organ, and therefore, to answer the question, who really treats psoriasis? The skin we treat, but actually you may have to visit a large number of specialists, except perhaps the surgeons. So psoriasis now has moved on from being a skin disease to a systemic disease. So what does your doctor take into account when they're deciding on treatment? So the type of psoriasis. Now, Monica has just shown you the various types of psoriasis, and then we look at the extent of involvement and severity. Generally, more than 5% to 10% means you've got moderately or a moderately severe disease. Then we look at the associations you have, like psoriatic arthritis. We look at your comorbidities, the other comorbidities. We're interested in knowing the status of your liver and renal, because when we give some of the drugs that we give, we may have to alter the treatment depending on the presence or absence of coexistent liver or renal disease. We definitely want to know the impact on quality of life. For example, if you look at a patient with a psoriatic plaque on the palm, you may think, oh, well, it's just on the palm and nowhere else. But for the patient, that it's almost a matter of life and death. So you may want to give more aggressive treatment, even though your inclination is to just get rid of it with topical treatment. So the impact on quality of life is extremely important. The other and most important thing is the socioeconomic status and affordability of treatment. Again, that's something we take into consideration. So what do we allopaths have to offer in the treatment of psoriasis? So we have topical treatment. By that we mean these are agents that are applied to the skin to reduce the itch, color, and scales. We have phototherapy, which is exposing the skin to ultraviolet light. Then when you have moderately severe disease, there's no point in just applying medications. So you need to give systemic treatment. It could be non-biologic therapy. And this generally broadly acts on the immune system and reduces the inflammation and improves the disease. Now you have a new class of drugs called biologics. And these are different in that they work within the body and target specific signaling pathways. And of course, no treatment of psoriasis is complete without the treatment of the comorbidities. So when do we give topical treatment? Usually it's indicated when you have mild limited psoriasis of the body, scalp, or the palmoplantar lesions. When I started life, there was just moisturizers, tar, salicylic acid, and topical steroids. Now, thankfully, there are a few more coming on, and and the doctor will decide which goes where. But I'd like to take this opportunity to educate you a bit about topical steroids, because that's something you can go to the pharmacy and just say, I've got a skin disease, and they'll give you one. But I would say stick to a doctor's prescription and do not go for over-the-counter preparations. Now, generally, use only mild steroids on the face and your body folds. Now, when you go to the chemist, he's going to give you, and you say, I've got a skin disease, he'll give you steroid in combination with antibiotics and antifungals, hoping one of these will work. Please don't go for that. The other inclination is extemporaneous dilution of the steroid. He'll give you a tube. You think, okay, let me just mix it around with something and then apply it. No, that doesn't work. Unless your doctor has prescribed it, please do not try any extemporaneous dilution. It just doesn't work. And generally don't use steroids for a long time. You usually use it for 2 weeks, and unless your dermatologist has advised you otherwise. So this is phototherapy. So this is given when you have large areas of the body involved. And there are 2 types. You can see the lights here. These emit either UVB or UVA. They're programmed to emit both, depending on what you want. We get that. And so you have narrow band ultraviolet B. This is a whole body chamber. And this is where you give hand and feet phototherapy. And then the other type of ultraviolet that we use is UVA. That does not work alone. We have to combine it with a medication, which is called Sorolin, and hence it's called Puba. And sometimes you may not have a chamber, so you harness the UVA from sunlight, and that's called Pubasol. Now, what about systemic non-biologic treatment? So if there are any patients with psoriasis who've tuned in, you'll have heard of methotrexate, acitretin, cyclosporin. So when do we prescribe this? We just prescribe this when your body surface area is about 5 to 10%, and psoriasis on special sites like the genital area, where it's very difficult to live with, to cope with, and and types like erythrodermic, exfoliative psoriasis that Monica showed you, pustular psoriasis, and psoriatic arthritis. What are the advantages of using systemic non-biologic therapy? One is we've had lots of experience. My slide, methotrexate is in use from 1958. They're relatively safe and they're cost effective. So that's systemic non-biologic treatment. Let's go to biologics. You'll hear a lot about it, especially if you're a patient with psoriasis. Now, what are these biologics? They are protein-based drugs that are derived from living cells that are cultured in the laboratory, and they alter the way the immune system works to improve psoriasis. When do we prescribe it? Usually when the systemic therapy fails. But in some cases, it may be first line for psoriatic arthritis, very severe psoriasis, erythrodermic, and pustular psoriasis. What are the advantages? It may be the most effective treatment for that condition. Disadvantages, prohibitively expensive, severe infections, and it may stop working after a time, and older patients are at a higher risk for side effects. So geriatric patients are not some you would give it with a low threshold. Your doctor is also going to tell you, do you want the biologic? You may hear it, or the biosimilar. So what's a biosimilar? It is a biologic that is highly similar to the original one that is already FDA approved. But there are minor differences between the two. Usually the efficacy is not compromised to a great extent. That brings us to integrated care of psoriasis. Now, I've been talking to you about allopathic treatment. So the question is, can I go ahead and have, other forms of treatment? One thing you need to inform your physician is whether you are on herbal or alternative remedies to prevent harmful interactions. So what are the things that you can combine with your allopathic treatment? Now, we usually give liquid paraffin and a whole host of moisturizers, but you may want to use olive oil or avocado oil, almond, coconut, aloe vera. Go ahead if it doesn't irritate your skin. What about diet and psoriasis? Like we showed you, obesity-associated psoriasis. So we know that obesity worsens psoriasis. You also have a lot of metabolic syndrome, etc., which is associated with psoriasis. So you need to tailor your diet to having more polyunsaturated fatty acids, less of red meat, more of high fiber. Omega-3 fatty acids do help, so that's available in fish. So and if you have gluten-sensitive enteropathy, which is sometimes associated with psoriasis, you should avoid wheat. So you modify your diet. You combine it with a healthy lifestyle with aerobic exercises. You may want to go to the Ayurvedic person for joint treatment. In all situations, go to someone who's qualified. So they know about proper positioning of the joints, which help to assist your mobility. Acupuncture is now recommended even by the WHO for about 50 diseases, which includes chronic pain. So I guess it includes psoriatic arthritis. Massage is good, but go to the right person. A wrong massage will worsen almost everything, including psoriasis. Mental health, as Monica said, is a big problem with psoriasis, and you need to learn coping strategies. It could be mindfulness, meditation, yoga, or you might have to seek help from elsewhere. So my last slide is just how do you live with psoriasis? How do you cope? So with employment and school, you need to increase the awareness that it's not contagious. You need to tell the school authorities that, listen, or you're at work, that you need flexible hours, you need to meet your doctors, you need to apply your ointments. Your uniforms, if they're short-sleeved and shorts, will expose elbows and knees, which are very classically affected by psoriasis. So you may need to wear clothing that hides these areas. You need to learn to avoid triggers, infections, treat them early, like strep. Medications, there are certain drugs that worsen psoriasis. So inform your doctor that you've got psoriasis so that they don't give you the drugs that worsen psoriasis. Stress, as I said, you need to handle it. Cold weather does worsen psoriasis. So in anticipation, start moisturizing excessively. You need to get your weight under control. Wear loose-fitting clothes, best to avoid belts to avoid friction. Tattooing, you'll get a plaque of psoriasis over your tattoo if you've got active psoriasis. The other thing is to manage itch. Very, very, very difficult for a patient with psoriasis. So moisturize, avoid harsh detergents and soaps. Keep your nails short. You scratch, and you can get psoriasis where you scratch. And antihistamines, you're tempted to take it, but please do not drive after taking the medicine. You're drowsy, your judgment goes. Thank you for your kind attention.
Thank you, Dr. Renu, for that very detailed explainer. We'll now move on to our final speaker for the day, Dr. N. Raja, who did his MBBS from Madras Medical College, Chennai, and MD in Internal Medicine from the Postgraduate Institute of Medical Education and Research, Chandigarh, and DM in Rheumatology from MMC, Chennai. He currently works as consultant rheumatologist at Naruvi Hospitals, Vellore. With an experience of over a decade in the field of rheumatology, Dr. Raja has treated more than 30,000 patients with rheumatic diseases. He has conducted numerous awareness programs for patients and continuing medical education programs for the medical community about the rheumatic diseases. His talk now is going to be on an overview of psoriatic arthritis. Welcome, Dr. Raja.
Thank you for the kind introduction. Are my slides visible?
Not yet.
One second. No?
No, sir.
So sharing the screen, one second. It is coming your screen shining here.
Yeah, yes, sir.
No?
Yes, sir. Now it's visible.
Okay. Thank you. It's clear, no?
Yes, sir.
Okay. I would be discussing a very important topic on psoriatic arthritis. See, what you have to remember is like what the previous speakers had suggested. See, psoriatic arthritis, see, 10 to 40% of patients with psoriasis can develop psoriatic arthritis. This is a very important point. So, psoriasis is not just a disease limited to skin, it can involve the joints also. And the most common age group is 30 to 50 years of age. But you have to remember that psoriatic arthritis can occur at any age. In fact, there is a huge entity called as juvenile psoriatic arthritis also, meaning psoriatic arthritis occurring before the age of 16. And psoriatic arthritis can occur in the elderly also. And the incidence of psoriatic arthritis is almost equal in men and women. Why I highlight this point is many rheumatological diseases, especially arthritis like rheumatoid arthritis, are more common in women, whereas in psoriatic arthritis, its incidence is almost equal. And the joints can be a single joint or it can involve multiple joints in psoriasis patients. So it's not a single domain. Actually, there are multiple domains of psoriatic arthritis. In fact, if you see, you can, as I pointed in the picture, some people can have only axial disease, meaning they can have only back pain. Some people can have only skin disease. Some people can have only nail lesions. Some people can have dactylitis, which I will be explaining later. Some people can have enthesitis, and some people can have arthritis. So the domains of psoriatic arthritis are numerous. Coming to the most common point, the point of discussion is psoriatic arthritis patterns. There are a number of patterns of psoriatic arthritis. Usually 5 patterns are commonly seen. The most common pattern is asymmetrical oligoarthritis. Second is symmetrical polyarthritis. I'm sorry for the technical terms, which I'll be explaining in the common layman terms. Distal interphalangeal arthritis, arthritis mutilans, and involvement of spinal column. So this is a classical picture of psoriatic arthritis. If you don't treat the psoriatic arthritis, you expect deformities like this. So it is not that the patient with psoriatic arthritis should not feel panicked or stressed seeing this image. It is just to highlight the fact that if you're not going to treat the psoriatic arthritis, the joint damage can be severe and permanent. And in the psoriatic arthritis, there are numerous types. As I already told you, one is symmetrical, meaning both sides of the hands, both sides of the feet will be involved at the same time. For some people, it can be asymmetrical, meaning only one hand, only one feet can also be involved. That is the difference between the two types. And you see here, you can see the joint pain, swelling, and deviation of the fingers. All these are features of peripheral arthritis and psoriasis. Another is axial arthritis. This is very important. A patient with psoriasis has low back pain. You should not ignore. So we know the prevalence of psoriasis comes to 2 to 3% in the general population. And if the patient with psoriasis is going to have a back pain, you should not ignore because psoriasis can involve the axial joints also, basic sacroiliac joints, the buttock area. If those joints are involved, the pathology can progress up or down and it can cause fusion of the spine, leading to bamboo spine. They'll have stiff neck. They will not be able to move the neck. They will not be able to bend. So this is called as psoriatic related ankylosing spondylitis. So this is another common joint involvement in psoriasis. In fact, the first thing which we discussed, the arthritis in the fingers is more common in women, whereas the psoriasis related ankylosing spondylitis is slightly more common in men. This is the type of psoriatic arthritis where the joints get completely damaged. This is called as arthritis mutilans, which occurs in 10%. That is, the patient won't cross the stage of initial arthritis. There will be aggressive form of arthritis where the joints will get damaged. And this is another type of psoriatic arthritis where you have distal interphalangeal. Distal means the joint which is close to the nails. In the fingers, if you see here, no, that the tip or in the toes. So they will have associated nail changes and they will have distal interphalangeal arthritis. So there's something called as enthesitis. I have marked the red spots are the sites of enthesis. Enthesitis means the area where your ligament or tendon attaches to the bone. Those areas are involved in psoriatic arthritis. So this is a huge picture, which I don't want to go into technical terms, but the commonest site of enthesitis is plantar fasciitis. So many people have plantar fasciitis, one of the common enthesite problem which many people occur, especially in middle-aged women. And if the patient is going to have psoriasis, the chances of plantar fasciitis also increases. What is dactylitis? Dactylitis is uniform swelling of the entire digit. For example, the entire finger or the entire toe will be swollen. as the picture showed, in the hand, you will have the right fifth, and in the toe, it is the left fourth. So finger is completely swollen, shiny. This is dactylitis. So what the point I want to stress here is, all these things are treatable. Only thing is, it has to be treated at the correct time. It's not to just say that every patient with psoriatic arthritis is going to land up in deformities. No, that's not we are trying to say here. So how do you diagnose psoriatic arthritis? It is usually a clinical diagnosis. Okay. So the patient with psoriasis is going to have joint pain. You're going to diagnose psoriatic arthritis. But you have to remember, it is not always the case. For some people, first arthritis can come, then psoriasis can come later. For some people, both the skin lesions and joint pain can occur together also. So a patient with arthritis, what as rheumatologists we do is we always search for occult psoriasis in presence of arthritis. Patient may not be aware that he or she has psoriasis anywhere in the body. So patient comes with arthritis, we always look at scalp, we look at the umbilicus, we look at the groin area, areas which generally patient won't see themselves or they are shy to tell. So we have to search for areas of occult psoriasis in presence of arthritis, and it's usually a clinical diagnosis. Clinical picture is mostly useful for diagnosis. Once the dermatologist gives a green signal it is psoriasis, we are going to diagnose psoriatic arthritis. Sometimes there are some doubts in psoriasis. They may do a skin biopsy to confirm the diagnosis of psoriasis. At the same time, if the patient does not have skin lesions now, patient has got only arthritis, as I already told you, in 1/3 of the cases, psoriasis can develop even 6 months, 1 year later. So there we have some parameters to diagnose psoriatic arthritis. It's more of a medical entity where you diagnose based on radiology, X-ray, MRI, CTs, and there are some classification criteria. As rheumatologists, we order laboratory parameters, especially ESR and CRP. This is to look for disease activity. And another common problem which we see is diagnosis of gout is made in patients with psoriatic arthritis. There's many of our patients nowadays with the advent of lot of technology, high uric acid with joint pain, a diagnosis of gout is made, and patient is given a list of instructions for management of gout. You must remember that in psoriatic arthritis, as the previous speaker, Dr. Monica, told, the cell turnover time is increased. It's quickened. It's not increased, quickened. So you will have high serum uric acid levels. For serum uric acid will be slightly elevated in patients with psoriatic arthritis, even though there is no gout. So that's a part of psoriasis and not a separate disease. And as I already told you, X-ray changes and CT and MRI is useful for assessment of extent of damage, and in sometimes it is useful for diagnosis also. And is it over? No. Psoriatic arthritis patients can have uveitis. Many patients with psoriasis or psoriatic arthritis, it is not necessary that the patient should have arthritis also. Even with plain psoriasis, they can have red eye. You call it as uveitis. Uveitis, an ophthalmologist, you need a slit lamp examination to diagnose uveitis, as like what Renu madam was telling. You may have to see multiple specialties. The ophthalmologist's role is here. And the pattern of uveitis also varies. Some people can have only one eye, red eye. Some people can have both eyes. Some people can have only limited portion of the eye. Some people can have entire portion of the eye. It occurs up to 10 to 20% of patients can have uveitis. And the problem is, if you don't diagnose uveitis and you don't treat properly, then there is a high chance that it can lead to complications like cataract, glaucoma, pressure high in the eye. And again, we have over-the-counter medicines. You ask for any medical shop, they're going to give a combination of steroid and antibiotics, eye drops. You put it, it is going to come, settle, but it will come back again. So that will cause damage. So you must remember that uveitis is a problem. Another important problem is metabolic syndrome. There are numerous studies which say that 40% of patients with psoriasis and psoriatic arthritis have metabolic syndrome. So why I am talking about these things in a patient with psoriatic arthritis? Because operation, it's like a surgery has to be success, and the patient also has to live long. Then only it's a successful surgery, no? So just by treating psoriatic arthritis and psoriasis, if you're not going to treat its associated diabetes, hypertension, cholesterol, the patient will suffer. So you have to remember that metabolic syndrome is a part of psoriatic arthritis. They can have diabetes, they can have hypertension, they can have high cholesterol, which leads to increased risk of cardiovascular diseases. So psoriasis and psoriatic arthritis patients should get treated and screened and treated for metabolic, and treatment of psoriatic arthritis reduces the risk of developing diabetes, hypertension, and other cardiovascular disease also. I think last few slides we are. So the management of psoriatic arthritis, I know this is completely medical. I don't want to go anything into this. What I want to tell you is, the madam has already suggested some of the drugs. Normally, psoriatic arthritis patients, we treat with conventional drug, simple drug, methotrexate. For some people, sulfasalazine, some people apremilast. Most of these drugs have a less chance of developing side effects. You treat them, the patient gets better. But a significant proportion may not respond to simple medications with these drugs. Then there we have to switch to biological therapies. And even biological therapies with proper screening protocol, many people do well. Basically, the comorbidities decide. And there are huge choices of drugs, especially in the last 10 years. The field of psoriasis and psoriatic arthritis has grown leaps and bounds. A lot of new drugs. We have enough expertise in managing these drugs. And the cost of the therapies also has come down, which compared much to before. But they need proper screening protocol and treatment. And before going to the take-home message, I would like just go back to the previous slide and mention that you cannot just treat skin lesions alone with topical therapy and say that the skin lesions will resolve, my joint pain also will come down. No, it is not true. Some patients with both skin disease and joint symptoms, skin disease can resolve, but joint symptoms can progress. Both run an independent course. So once the joint is involved, we need oral medications for treatment of psoriatic arthritis. Okay? And another common question is asked is, I think this, I was trying to, because somebody asked a question, so I'm trying to answer this. Medicines related side effects, usually when used by a qualified professional and appropriately monitored, they are safe. But yes, obviously there are some patients who do develop side effects which can be managed properly. Okay, so what are the take-home messages? The purpose is a patient, I think the first line I was trying to say that do not ignore joint symptoms in patients with psoriasis. It's not psoriatic arthritis. Sorry for the thing. So a patient with psoriasis, either the patient himself or the consulting physician, whoever sees complaints of joint pain or joint symptoms, do not ignore it. Just don't say that because you worked yesterday, you stood for 1 hour, you stood for 2 hours, you were lifting weight, so you developed back pain. You had eaten this vegetable, you had eaten potato. All those things don't have a real scientific explanation. So do not ignore joint symptoms in patients with psoriatic arthritis. Vice versa, if a patient comes with joint symptoms, from the patient side or from a general practitioner who is listening this, they should search for psoriasis and ask for psoriasis. Patient will know that they have some skin lesions. They will not tell you if they don't ask. That point also has to be treated. And get treated by a proper specialist. Get treated by dermatologists for skin lesions and rheumatologists for joints. This is important. Even with 10 years of practice, somebody shows me a skin lesion with psoriatic arthritis, I say, please show to dermatologist, because they are the best person to treat for the skin disease. Because we don't know the exact dose. The medical shop person does not know how long to use, what are the side effects. And similarly, for joint symptoms, you get treated for rheumatologist, because by treating early, you are going to prevent deformity. The quality of life will be improved. And remember, psoriatic arthritis is a systemic disease and it can involve eye. As I already told you, it can cause cardiovascular events. And from your side, patient asks me, so what should I do? One is find the correct specialist for this. Second, follow his instructions. Other than this, eat healthy. All these autoimmune diseases, taking a lot of fat and saturated fat and high inflammatory diet are shown to worsen the disease. So eat healthy, like we know, eat vegetables, eat fruits, less of oil, eat lean meat, reduce stress levels. Emotional stress is a significant risk factor for worsening of all these things. And maintain ideal body weight and have a good sleep. Very, thank you for the opportunity. Thank you for the Hindu team and Naruvi for giving us, all the three of us, the opportunity. And any questions are welcome. Thank you.
Thank you, Dr. Raja, for that nice presentation. I just have a quick doubt to be cleared. Like, till a patient reaches the doctor for treatment, what is that very first stage, when a patient should get alert and seek treatment? Because if the psoriasis starts, as you said, with a rash, and many times when we see a body rash, we ourselves think that it could be of various reasons and we keep treating it on our own. So what is there a time span, like, a patient should be really going out to a doctor immediately, or try some home remedies thinking that it will be okay? I mean, how do we get that alert at home, the very first instance?
Who's the question to, Soma?
Ma'am, you can answer, you can take it.
Right, sure. So, psoriasis is a disease that will make you go to a doctor. It's so itchy. But when should you go? If you have a single lesion and a single area involved and you're applying your moisturizer and you're comfortable, it's okay. But if it starts spreading, you get 3-4 lesions, best to go to a doctor, because at that time we can halt further progress. But as I said, psoriasis is one disease that will just bring you to the doctor because it's so itchy. And yeah, so I'm not sure if I answered your question, but if you get more than one lesion and it's there, or it stays there and hasn't gone in 1 month, then it needs attention. It doesn't have to be psoriasis. So if you have a red raised lesion, it's itchy and it persists, and nothing of your home remedies works for 1 month, please go to a doctor. It may not be psoriasis, it could be anything under the sun. So that time you need a general practitioner or a dermatologist to see you.
Right. Thank you. So we already have a lot of questions and they are very specific as we were expecting. So I'll start taking them. So somebody is writing that I've been undergoing treatment for scalp psoriasis from 2017. And 2 years back, my condition aggravated to psoriatic arthritis. And since then, I'm consulting a rheumatologist and under medication for psoriatic arthritis. Are there chances of my autoimmune disorder cause more health conditions later? So maybe Dr. Raja, this is for you.
I think as the disease is well controlled, you don't have to worry. Basically, you've treated well, you don't have any joint symptoms, you're doing well, it's good. See, future diseases, as I already told you, just screen for normal metabolic diseases, diabetes, hypertension, and cholesterol. If they're all normal, just maintain ideal body weight and continue the medications. I think in the future, like what will you develop? It's very difficult to say no, but as such, the lifespan, if you treat well, it's not going to get reduced, and your quality of life, you can maintain it very well. Just keep following up with the rheumatologist. Should be fine.
Dr. Renu, you had mentioned biologics in your presentation. So Dr. Oscar is asking, is biologics a good method of treatment because it has side effects? And would you recommend use of biologics?
Okay, so to answer it, so it's got two parts. So the first question is, when would I recommend it? As I said, it's okay. There are more often than not for the skin, it is failure of systemic therapy. Okay. The next question is side effects. Both the traditional and biologics, both of them have side effects. And there are different. They're actually a different set of side effects. So would I prescribe biologics? Yes. If systemic treatment failed, I would prescribe biologic. Which biologic would I prescribe at the moment? With what availability we have, is probably I would go for the IL-17 blockers. They tend to have less side effects. So I'm not sure if that answers your question. It's not going to be my first go-to, but it may be my eventual go-to. Because cost is a prohibitive factor.
Yeah, that's what I was coming to. You said cost is a prohibitive factor. So how much does it cost actually? Because it's going to be lifelong after that?
Yeah, okay. Now, the good thing about biologics is that you can give it for a much longer period than you can for the traditional anti-psoriatic medicines. How long? So you can give it forever, but these actually wane off. Their efficacy wanes off. So after some time, you will have to switch to another form of treatment. So one vial of an IL-17 blocker is 150 milligrams is about 19,000 rupees. So if you look, I need 2 vials of it for 1 injection, and this over a period of years, you can imagine how much it's going to cost the patient. So we cannot give treatment that will cost your life and you have to sell your house and things like that. So that is what limits the treatment at the moment with biologics.
So Anjala Shah is saying that she's a 26-year-old woman who has been diagnosed with psoriasis when she was 4 years old. And it was in remission for past 5 years. Right now, she's 7 months pregnant with severe spike of psoriatic lesions. And she wants to know about psoriasis spike during pregnancy, the complications it could lead to, and how it can be managed. So who would like to take that?
Yeah, I think I will have to. Yeah, okay. So your psoriatic disease, what treatment? It depends on what you have to go for. Okay, the first question is, will it affect your baby? I presume you've got plaque type of psoriasis and not erythrodermic or pustular. The pustular form can affect the baby, but the other forms do not affect the baby. So in those terms, it is okay. Now, usually when you have psoriasis at this stage, we like to optimize the topical treatment. And there are certain biologics that we can give you which are safe during pregnancy, but the traditional systemic medications are not really safe. That is, I'm talking about methotrexate and I'm talking about acetretin. Absolutely not. So we are a little limited on what we can give you. But if you talk to your doctor, they might suggest optimizing topicals. You may go in for phototherapy. You have to take folic acid when you go. Otherwise, quite safe, especially late in pregnancy. And there are certain biologics that can be tried.
Dr. Monica, would you like to answer this? Tirumala Reddy says his daughter is suffering from epidermodysplasia varicoformosis.
It's not a
So is there any?
psoriasis. It's not a psoriasis.
I see. Okay, so he's wanting to know if there's any treatment for this. I don't know why he put the question here.
Yeah,
Maybe
it's
the
not
word
psoriasis.
the word epidermo is there.
Okay.
Rashmi Mishra says any local application works only for a few days and then becomes ineffective. So, Dr. Monica.
See, it's not like it becomes ineffective. It depends on the amount of lesions they're having. So it works for a while, but it's not like it will stop working. But steroids are certain medications which shouldn't be continued by themselves for longer time. So yes, if something is not working out, we need to change it. If tolerance develops to the condition, so yes, if you have used it for a year or more than a year, then you get tolerance to the medication, and then we need to change the topical.
Okay. Dr. Raja, Rashmi wants to know how to handle the small joint psoriatic arthritis. Is there any different way of
generally, actually, if you see small joint arthritis, it's easier to treat compared to the axial because many medicines are there for small joint arthritis. Most people will respond to a simple medication, methotrexate, normal drug which we use. And for some people, there are additional options. I think it is, we have around 60 to 70% chance that with simple medications, with cost-effective therapies, peripheral arthritis, that is small joint arthritis, can be very well controlled in patients with psoriatic arthritis. And of course, there's a small percentage where you may need biological therapy also.
Mohan Raj wants to know how can we differentiate between arthritis and psoriatic arthritis?
See, again, I think it's, I'll be answering this. See, arthritis has got so many causes. Arthritis means there is inflammation of the joints. You have pain in the joint, swelling in the joint, pain while moving the joint, early morning stiffness. There are so many types of arthritis. We have a very common type of osteoarthritis where aged people can develop knee pain, back pain. Some people have rheumatoid arthritis. Rheumatoid arthritis where you have the joint pain and swelling. Some people have post-chikungunya arthritis. There is something called as gouty arthritis. So arthritis is a huge term where there are so many causes. One of the causes is psoriatic arthritis. Out of so many causes of arthritis, one cause of arthritis is psoriatic arthritis. Okay. So it's a part of the overall arthritis. It's not a separate thing.
Right. And an add-on is, does it respond with methotrexate?
Yes, that's already told. It is the first line of drug and many people do respond. Only thing is they should take for enough period of time and they should take the proper dosage. Both are important. They do develop. They do respond. It's like what we treat most commonly and many people respond very well with oral methotrexate. And off late, there are a lot of newer drugs are there. Like there is something called as apremilast, which doesn't have much side effect. And newer molecules, JAK inhibitors, tofacitinib, so many drugs are there. See, all these problems, no, for some patients, some drug might work well. There is no uniform rule here. We cannot predict for which patient, which drug is the best. But as far as the guideline says, the number one drug is methotrexate and 60 to 70% do respond well.
Dr. Renu, does direct sunlight help in treating psoriasis? And also the fact that a lot of people use a lot of desi oils and ointments. So you did mention about certain modes of treatment, but then there are still questions. Maybe
can you just sit in the sun? Sorry. Yeah. Okay. You can expose yourself to sunlight for short periods. Don't sit for long and bake your skin. It's not going to evaporate the psoriasis. Early morning sun, you give it a little bit. If you don't have facilities for phototherapy, yes, we do advocate. The 10 a.m. to 3 p.m. sunlight, though it might contain the wavelengths that we need for psoriasis, will also put you at risk for skin cancer. So I don't think I would advocate that. Yeah, sunlight does help psoriasis. Yeah, that's the short answer.
Doraiswamy Ramaswamy has itching around scrotum and using moisturizer and Lulifin. But he says it's not going, and it's been there for more than 40 years. And I'm suffering because of this. And
Is it
sometimes
psoriasis?
that's what he has written. No, he says itching around scrotum.
Yeah, so that has to be evaluated. It doesn't say it's psoriasis. So he's being treated with antifungals. So unless you get evaluated, and then you can't really treat it. You need to know what it's due to.
Okay.
Yeah.
So, Dr. Monica, like you ended your presentation by saying that psoriasis is not curable but treatable. So somebody is saying, how far is it manageable?
So it is something like depending on the treatment what you're getting. So we can manage it to a very good extent. But yes, you'll have phases of remission in it. That is what need to be considered. So you have a high-low in psoriasis. So once you're on treatment, mostly it will come under control. So, but there's no guarantee that it will not be coming again back to you. So once we get it back, we need to get it treated again. That's it.
So Valyappan is asking that what are the side effects that we may get by continued medication? And what form of psoriasis develops into arthritis? I mean, there are a lot of repeated questions as well. And what are the other complications that one needs to be alert to identify?
Okay. So I'll be answering this. See, we cannot predict which patients with psoriasis will develop arthritis, but there are some things. Patient with scalp psoriasis, the nail psoriasis, psoriasis in the groin area, over the anal area, those patients, there is a chance that they may develop psoriatic arthritis. But there is no specific factor. We cannot just pinpoint and say this will develop and these won't develop. You can't say. Some people can have only psoriasis over the fingers, can develop arthritis also. So that is one thing. Second is the medication side effect, what he was asking. So all these medications, so we know there is these side effects don't suddenly come out of the blue because these drugs are well studied for centuries, at least conventional drugs, not centuries, maybe decades. For those drugs, generally we monitor the complete blood count, liver functions, and creatinine. Okay. What the expect is some people, the WBC or the platelets can come down. For some people, the liver enzymes can rise. But if you are going to do the test appropriately at the correct interval of time and you adjust the dose, many of them recover. So the point I want to convey is, see, we know it's an open forum and we are going to discuss about the side effect. So we cannot refutely say that nobody will develop side effect. That is not what we are going to tell. But these side effects are easily detectable and manageable. That's the point I want to tell. Not everybody are going to develop the side effects, and not even those patients who develop side effects can be easily picked up and treated. But of course, there is a very small percentage of patients who do develop severe effects without any prior warning, though the percentage is very, very small. Biological therapies, like what is a point of interest now in psoriatic arthritis, in Indian scenario, we have a risk of tuberculosis. Tuberculosis risk is there. So that point, so we do a protocol. There is a TB screening protocol. We do imaging of the chest. We do test for latent tuberculosis. If all are negative, we can use the biological therapies with relatively good safety. Only if we don't follow the protocol and we are not going to follow the proper screening methods, then there is a high chance of developing problem. So we have enough vaccines to prevent. We have vaccines for herpes zoster, shingles vaccine. We have vaccines for pneumococcal influenza. If you use these vaccines properly and follow the instructions, these drugs are relatively safe. But of course, you have to be very careful while monitoring.
A basic question which a lot of people are asking is, when I have arthritis, who do we consult? A skin specialist or an arthritis specialist? Like, how does a patient decide which doctor to go to?
Yeah. So as I already told you, psoriatic arthritis, I treat with all medicines. But moment I see a skin lesion, I refer to a dermatologist. Okay, I think vice versa, the dermatologist, at least what we are having in our hospital, Naruvi, is any patient with psoriasis with musculoskeletal complaints, they are being referred to me. So it's a team approach, combined approach, where you need help of both. You cannot pinpoint and say one. But only point I want to tell is, treating skin alone is not enough, because some people have the misconceptions that treating skin psoriasis will cure arthritis per se. I think Renu madam will be able to add more into this specific question. She'll have definite inputs regarding this. It's an interesting question what they had asked. Who should we consider?
You, the rheumatologist. Even if they
No,
don't come
both.
to me, I will send them to the rheumatologist.
For the skin, ma'am, skin we need a lot of
Yeah,
both.
it's
We
a
need
combined treatment. It's combined.
combined treatment. Nobody can.
And how far conventional physiotherapy improves psoriatic arthritis?
Yes, see, obviously physiotherapy has a huge role here. Patient with psoriatic arthritis, if the joints are not damaged, it's very good. They can do joint strengthening, muscle strengthening. But once the joints are damaged, then there are a lot of methods. There are splints, there are orthosis, and so many things are there. Can help.
Dr. Renu, somebody is asking about the brand of moisturizer, which is the best one for Palmer and plantar psoriasis.
I cannot endorse a brand, but I can tell you that it should have lactic acid and urea, and if it has a keratolytic with it, that's a good thing to use.
And is steroid injection given commonly for skin psoriasis? Like some doctor has prescribed Vasuki one every 2 to 3 months. So
I don't know what that is. I'm sorry, I'm not familiar with that trade name. Of
okay.
course, we do give for very, very thick plaques of psoriasis, we do give injections into it. That's usually we give steroid injections into the plaque. That's for thick plaques of psoriasis. But it's not a
Okay. Ojashwin has patches in the legs and has used apremilast for 2 years. Should I stop now and go for biologics, which is the
honestly,
best?
that's not something I can do without an assessment, and it wouldn't be correct.
Right. Okay, then maybe one of you, maybe Dr. Monica, you could throw some light on diet because there are again questions related to food. Like, ma'am did explain a little bit whether I should have non-veg, whether it increases the condition. Somebody says I'm not allergic to milk, but any concentrated processed milk derivatives like the Bengali sweets, when I eat, I get rashes on my forehead and scalp. So if you could just throw some light on what to eat and what not to eat.
So the rashes which he's getting to the food may not be related to the psoriasis per se. Maybe he has some other skin condition, so we need to look into that. And coming to diet in psoriasis, I would like to tell that always a healthy diet, like a non-fat containing diet, a Mediterranean diet, would be much helpful in taking. Because like the processed foods which we have, the high fat sugar, the high fat or the high sugar, they all increase the inflammation in your body. So you need to have low fat diet so that the psoriasis inflammation doesn't increase.
Mhm. Is there a relationship between psoriasis and ulcerative colitis? Because both are autoimmune.
Yes.
So, what precautions can one take? Dr. Arun Kumar Nagasundaram wants to know.
Precautions in
Yeah.
what terms? I mean, it is one of the comorbidities of psoriasis. I wouldn't give an IL-17 blocker to such a patient. It can worsen his ulcerative colitis. Is my thinking. Am I right, Raja? IL-17 blockers with coexistent ulcerative colitis, you don't give, right?
You should not give serotonin.
Yeah, you don't give. That's one thing you would avoid. But otherwise, you need to get both treated.
So there is approximately twofold increased risk of psoriasis patients developing ulcerative colitis, and ulcerative colitis patients also there's a lot of studies are there where psoriasis patients have increased risk of developing inflammatory bowel disease, and monoclonal antibodies are better useful here. Adalimumab, infliximab, which will cover both if needed biological therapy.
So, can psoriasis also turn into vitiligo at a later stage?
They can coexist. One doesn't turn into the other, they can coexist.
Okay. And similar, likewise, chronic back pain.
That's what Raja was talking about, yes.
Right. Dr. Renu, Pavitra has asked you a question. Could you please brief on the unpredictability of the disease? My mother suffers from aggressive psoriasis and its behavior seems very inconsistent for each season, each year, and environmental condition. Is there a scientific basis for this?
I'm a little confused because psoriasis is known for its unpredictability, and psoriasis worsens in winter. There are a host of triggers for psoriasis, so that's what makes its course so unpredictable. You might just unknowingly be having one of those triggers in your life. It could be stress, it could be infection, it could be obesity, it could be it could be a metabolic syndrome. So it could be any of these that worsen psoriasis. So it is an unpredictable disease. I wish it was predictable. It would have made treatment very easy. So unpredictability is a part and parcel of psoriasis. But I'm sure if you take her to a dermatologist, the dermatologist will be able to get you a treatment plan and to look at the whole spectrum that she's going through and giving you the right medicine. It's just a question of controlling it.
Right. I think I'll have to wrap up because we are short on time. Only just one last question. I think maybe some people joined late, and there are a lot of questions which are saying, does obesity affect? Will exercise help? So if one of you could quickly sum up, the lifestyle habits one which needs to follow as an awareness. Maybe Dr. Monica?
Yeah. So obesity is surely related to psoriasis, and as I have discussed, there is an obesity-associated psoriasis. So whenever you have obesity, it increases the inflammation in your body. So certain lifestyle changes like low-fat diet, like I've already discussed, like everything which contains low on fat and no processed foods, all this will help the patient. Once the obesity is reduced, there are studies which show that weight loss has caused improvement in the psoriasis. So once the patient loses weight, you see that there is a rapid progress, like a very good improvement in the psoriatic lesions. So it might also help with the psoriatic arthritis, if I'm not wrong. And so definitely a low-fat diet, like all the healthy diet which you can take, will really help.
Right. So thank you very much, Dr. Renu, Dr. Raja, and Dr. Monica for sparing time and explaining in detail and patiently taking all the questions. We still have quite a few unanswered, and if you wish, you could answer them specifically, individually after the program. So I thank all the audience who joined this webinar on psoriasis and psoriatic arthritis, an overview which was presented by Naruvi Hospitals, Vellore, and the Hindu Wellness Series. Thank you so much.
Thank you.
Thank you. Thank you so much.